Good evening, everyone, and welcome to another LEJEndo, which is the List and the Materials Journal Club. We've got a quite exciting, I think, really nice session today, where we're going to go through some really nice, interesting papers. I know that Shaheen wants to introduce one of the speakers today, who is his old fellow. So, Shaheen, over to you for the first introduction.
Yes. Yeah, I'm in Paris at a conference. Everything sort of has clashed with each other, and this event that I need to be at is right at the time of LEJEndo. But I just wanted to make sure that I'm there at least at the beginning, because I think this is a special session. Kyle Fleischer, who was my fellow until October, is going to present the results of Venus study. And this is a study that has been, I think, active for a few years, I would say since 2016, 17, but the last 2-3 years, Kyle and Avril and Ben have worked quite a lot, but Kyle was the person who really brought it all together, and this led to the publication of the validation study. Kyle is someone that I think in the next few years is you're going to hear a lot about. He's a very academic person, and I'm pretty sure that he will be Professor Fleischer soon. He has worked really hard on this project, and I'm going to just listen in and sit in the background. So the study is the validation study of visual numeric endometriosis staging system. I'm going to let Kyle introduce the study and do the presentation for you. By the way, I'm in front of the very nice restaurant in Paris. I'm really looking forward to this, but I will pay some attention to what Kyle has to say as well.
Brilliant. Kyle, do you want to start then?
Yeah, grand. So, well, thank you for that very warm welcome. I'll just get everything up. So, yes. So this is Venus. This is the visual numeric endometriosis scoring system for mapping surgical findings, and this is a validation study. My name's Kyle. I'm a resident currently working at Frimley Park Hospital, and I was a clinical research fellow at CMIG London last year. And I need to say a massive thank you to everyone involved in this paper, but especially Ben Mondelli, who was instrumental in data collection, but also Mikey as well, who actually got the videos together with Ben in the initial stages, and of course to Mr. Ghazali, who conceptualized Venus. But this really was a labor of love, and it took time to get things over the line. So thank you for everyone that was involved. So if you do want to go away and take a deep dive into this study, it is published as of October, I believe, in FEVO, which is an open access journal. And please do go away and have a read yourself. So we'll start and touch on a bit of background. There are over 20 published endometriosis classification systems that have been proposed of the last 4 decades, and really a critical appraisal is beyond the scope of both this paper and today's talk. But more importantly, the search for a universally accepted language for communicating the complexity and severity of endometriosis continues. The revised ASRM system is still the most widely used, and we still see it being used in publications. But that being said, most experts would agree that the system is not entirely fit for purpose, particularly for accurate description of deep disease. Other published systems do indeed have merits, such as #Engine, which provides a comprehensive definition of deep disease, and AAGL, that takes into account surgeon-derived complexity. Equally, EFI is validated for potential fertility outcomes. But what all this means really is that unfortunately, there's still no universally accepted system that is easy to use, maps the location of the disease, and is also easy to understand, not just for clinicians, but for patients. In this image, taken from an editorial by Mr. Ghazali and Prof. Sarudigan in Facts, Views and Vision, the important facets of a classification system are summarized. And when taking into account all of the pillars that are needed to provide a good system, it's really clear that creating the perfect one is a significant challenge. Which brings us to the history and rationale for Venus. So it was conceptualized in 2014 to find a way to record and communicate surgical findings, as well as the complexity of this disease at a busy endometriosis referral center. The aim was to create a system that was precise, but also easy to use and understand. A system similar to POP-Q with pelvic organ prolapse, but for endometriosis. It was devised to closely mirror the pelvic survey at laparoscopy. Not only could this visual representation be easy to understand, but also encompass the laterality of the disease. The first iteration of Venus had a severity scale of 0 to 6 with 8 anatomical compartments, and in a 2015 initial study as part of a postgraduate master's thesis, the initial findings showed excellent inter and intra observer validity. But following consultation with multiple international experts, Venus was refined and simplified to include only 4 levels of severity, and a further compartment was added in order to distinguish vaginal involvement from rectal disease. Which brings us to its current iteration. So this slide describes the compartments and levels of disease severity for Venus, with bilateral side compartments comprising of the adnexa, pelvic sidewalls, and uterosacral ligaments, with central compartment involving the UV fold, vagina, and rectum/pouch of Douglas. Severity ranges from no macroscopic evidence of endometriosis to disease infiltrating almost the full thickness of a structure, such that the complete excision would likely require opening of the lumen. For example, in the rectum, either a discoid or a segmental resection to completely remove the disease. In terms of what we would define as superficial, we would consider any endometriosis that goes beyond the fine peritoneal layer as deep disease. Here is a laparoscopic image representing the pelvic compartments. The authors are mindful that there are no strict borders between some compartments. For example, a large nodule involving the uterosacral ligament is also likely to involve the parametrium, and if there are adhesions, therefore the rectum as well. This is how we would document Venus. This would indicate superficial disease of the left adnexa, deep but non-adherent disease of the left uterosacral ligament, a full thickness bladder nodule that would require partial bladder cystectomy to completely excise, and so on. It can be written in a linear fashion or in a grid fashion, and the grid fashion aids the visual representation, especially in one's mind's eye, of how the disease might look when it's described. The extrapelvic disease and specific anatomical structures are not categorized within Venus. Instead, the surgeon can add any additional information as a note, such as Appendix 3, Appendix 4, Diaphragm 1, 2, 3, 4, if there are extrapelvic structures that are involved. The reason extrapelvic structures are not included is that it detracts away from the simplicity of the system. So I'm going to show you now examples of each level of severity, and these are the video vignettes that were used within the study, which we'll go on to discuss in a second. So this would be Venus 1, so disease that's with either superficial or confined to the fine peritoneal layer. This is Venus 2, so this represents disease that is slightly deeper. It might be going into some surrounding visceral fat. It goes beyond that fine peritoneal layer, but is not necessarily adherent to other structures. An example in the adnexa would be an endometrioma that isn't adherent to anything surrounding it, or it simply has filmy adhesions to areas surrounding it. Venus 3 represents deep disease with associated adhesions, and a good way to think about this is anywhere where you're performing a shave, and or if there's an endometrioma that is particularly adherent to the pelvic sidewall and or the uterosacral ligaments. And finally, we have Venus 4, where you're needing to essentially open and or remove that area of disease from a certain structure or organ in order to completely excise it, whether that be the rectum, the UV fold where you're opening the bladder, the vagina where you're performing a partial vaginectomy, or say here on the pelvic sidewall where there's infiltration of the ureter. So what we were trying to achieve with this study was to determine whether this description of this classification system, so Venus, is a reliable system to communicate surgical findings between observers. The study took the format of a survey embedded with 93 videos and a series of questions regarding each scorer's seniority, level of experience in endometriosis, volume of cases, and familiarity with other classification systems. A brief introduction to Venus was provided, and each video clip showed a compartment of the pelvis that the observers were asked to give a score from 1 to 4. No clips of Venus 0 were displayed, as the purpose of the study was to not assess the scorer's ability to recognize endometriosis. 210 were invited, 54 initiated the survey, and 50 completed the survey. In terms of the statistical analysis, 3 different measures to assess inter-rater reliability were used. ICC, or intra-class correlation coefficient, essentially assesses clusters of data and determines if their correlation is due to chance. Kappa coefficients analyze the difference between 2 scorers and determines if this relationship could be due to chance. For the purpose of this study, the standard score set by SK, Shaheen Ghazali, represented scorer 1, and the pooled observed scorers represent scorer 2. Whereas Cohen-Kappa coefficients only assess scores are different, quadratic weighted kappa takes into account the magnitude of difference between the scorers. For example, scores of 1 score difference will result in a stronger coefficient. And here's the beginning of some of our results. So here's a table providing the number of correct scores and scores with 1 score difference according to the anatomical compartments. The highest and lowest level of agreement was within the vaginal and uterosacral ligament, respectively. This graphic provides a visual representation of agreement according to Venus severity. The highest and lowest percentage agreement with the reference score was seen in Venus 4 and Venus 1, respectively. 17 clips of Venus 4 were shown. 97% were in perfect agreement with the reference score. The remaining 3% scored the videos as Venus 3. In terms of the statistical analysis, as mentioned before, ICC can be used to measure reproducibility between observers in relation to clusters of data. Total ICC over all scores was 0.905, which would be classified as excellent. The vaginal compartment shows a poor ICC compared to the others. This may represent a statistical anomaly, as percentage agreement was actually highest for this compartment. 87.6% perfect agreement with the reference score. This may be explained by the high reference severity score the videos demonstrated. We didn't have many Venus 1 or Venus 2 for the vaginal compartment. These are the results of the Cohen and the quadratic weighted kappa, where we've said again that weighted kappa adjusts for the range of disagreement between observers. Since there was a high proportion of responses with only one score difference to the reference score, the total weighted kappa coefficient is 0.864, which would be classified as strong, and 0.678 for the Cohen kappa, which would be classified as moderate. So from what we found, our study suggests that Venus overall has a good inter-observer reproducibility, classifying ICC as excellent, Cohen kappa as moderate, and quadratic weighted kappa as strong. Agreement correlation is stronger with more severe disease, with 97% perfect agreement for Venus sport. The weakest correlation was noted with less severe disease. With regards to what we have concluded, we feel that Venus is probably a good tool in its current iteration as a surgical mapping tool. And there are things on the way, which I'll discuss in a second, that make it potentially more comprehensive classification and staging tool as well. Some of the limitations of our study is that the location of disease was not assessed, that these are video vignettes, so individuals can't have tactile feedback, and that the vagina ICC is a possible anomaly, even though the agreement was high. So what's next for Venus? So one of the strengths we feel with Venus is that the numerical compartment system leads itself to potential statistical analysis and provides a potential platform for further research. There can be specific investigation of surgical complexity based on anatomical compartment, and this weighting can be considered in the development of a total Venus staging system. Further studies can also explore if there's a correlation between Venus with symptoms, preoperative imaging, which is something we're thinking about at the moment, and surgical complexity. So with that, I'm happy to field any questions and go from there.
Brilliant presentation, Kyle. Do we have any questions from the audience? If you do, can you please type them out in the Q&A session? Shaheen, do you have
Kyle, yeah, a great presentation. I don't think I could have summarized Venus as beautifully. What we've found, because we use Venus now in our practice routinely, I have to say we sometimes struggle to decide whether this is a 2 or a 3. You know, between 3 and a 4, it's always clear. Between 1 and a 2, it's always clear. Between 2 and 3, it's sometimes not clear. But I think that's to do with the nature of the disease. You know, it's just we're dealing with a condition where the definitions are not clear, and even when you've completed an operation, sometimes the lines are not that sharp. But what we find really useful with Venus is that I can describe a whole case to Mikey by 9 numbers, and he knows exactly what I've done. You know, if I say we just did an operation and it was a Venus 133424111, he can picture that surgery in his mind. You know, he knows which ovary was involved and how. He knows that there was a bladder nodule. He knows, you know, so this is really the strength of Venus. I think that a combination of systems that includes perhaps #Enzian and Venus would probably be the right way forward to try and you know, reach the goal.
So yeah, and I know we've spent a lot of time working on translation of systems to another, and we're figuring those bits out. But I think, and I know you agree with this, that I think only through huge amounts of data inputted in an easy way for people to use essentially anywhere, can we start to get to the bottom of what does one thing mean to another and actually truly have a universal language.
Yes, I agree. It's It's not, I think it's not a topic that is going to have an easy solution. It's just making step towards a better solution. And again, as we all know, we think that technology is going to solve a lot of that problem. So getting to a place where you just describe what you've done and not worry about the staging. And AI will actually tell you what the severity of disease in each compartment was for benchmarking purposes. I'm going to say goodbye to you. Thank you very much, and well done, Kyle. I'm going to go in and I've been quite
Thank you
rude
very
now
much.
to the other guests, standing aside and listening to this. So great. Thank you very much, guys.
Enjoy.
Thanks, Shaheen.
Have a good
Enjoy.
meeting. Bye-bye.
Thank you.
Bye, bye-bye. Right. I don't know if we have any questions from the audience. Have you guys noticed? Let me have a look. There's nothing in the Q&A. Right. Okay, Kyle, this was a great presentation as always. Should we move into the smaller articles now?
Sounds good.
Who's presenting? Is it you?
I am sorry, I was on mute. Yes, that would be a good idea. Can you see my screen?
Yeah.
Is it good, full?
Mm-hmm.
Okay, so hi, good evening, everyone. Thank you for joining us here at LEJEndo. I hope you enjoyed Kyle's presentation. So one of the small papers I'm going to present on is a systematic review and meta-analysis looking at the effects of anti-inflammatory dietary supplements on pelvic pain in females with endometriosis. And this was produced by a group from Tehran in Iran and recently published in the International Journal of Obstetrics and Gynecology. So they had quite a very strict inclusion criteria. They included RCTs, which looked at adults over 18 years old with endometriosis. The investigations needed to have a follow-up of 4 weeks or longer, and they had to be assessing this group against a control group. These trials need to have reported a change in pelvic pain as an outcome of the outcome of the study, and the change in the pelvic pain they must have provided the means and standard deviations of them. They excluded studies which had shorter than 4 weeks of the study if it included pregnant women, children, or adolescent, or if it did not report any sufficient information to estimate changes in the pelvic pain scores. So after all of that, they included 9 studies. Over here, you can see 10 arms, but one of them is made up of 2 of the arms are made up of one study. Nodler et al. Looked at the effect of vitamin D, omega-3 against a placebo. So we have 10 arms here. So the mean age range of the patients in the study ranged from 20 to 36 years old. In terms of their body mass index, it ranged from 19.9 to 26.2. So they are looking at a very slim group of ladies. None of them was overweight. And these are the interventions which the patients had. The first one, I wasn't familiar with what it was. I had to Google it. And it's just a naturally occurring fatty acid ethanolamide, which is known to have anti-inflammatory and pain-relieving properties. The rest, we have vitamin D, melatonin, omega-3, vitamin C, and E. So what did it show? It showed, as you can see, the rhombus did not cross the midline, so it showed a significant decrease in the pelvic pain following supplementation with anti-inflammatory properties. They also did a subgroup analysis, which showed that anti-inflammatory dietary supplements could significantly decrease pelvic pain in women with endo if these women were age 32 or above. The duration of the study was more than 8 weeks. If the intervention was a vitamin as opposed to a supplement, if the patient had endometriosis stage was more than 2, and if their BMI was more than 32 as well. So this was the first meta-analysis to look at dietary supplementation, anti-inflammatory supplementation on the effects of pelvic pain in women with endometriosis. In terms of the weakness of the studies, they mentioned that in each study they have different types of population with different age, different demographics, and they didn't consider things like physical activity, physiotherapy, which could also affect their pain. In terms of their major strong points, they define this as their subgroup analysis looking at the different variables that could further improve the patient's pain. And that's all from me. Thank you.
I like this type of studies. I don't know about everyone else, but I really enjoy listening and reading studies that exactly like this. I have a quick couple of questions. What was the diagnostic criteria for them? What are they
So they
doing?
didn't mention what the diagnostic criteria, because they didn't go through each different kind of papers. They just said as long as the paper had this met this criteria, which is endometriosis 1, diagnosed with endometriosis, they were included in the study. But unfortunately, I did not go through the different
Right.
the 10 different papers.
Sure. And those patients were presumably not operated, so they were not post-operative patients. Is that right?
Again, they didn't mention this in the study, what type of patients they were. The only thing that they mentioned with this study is some of them did receive hormonal treatment as an adjunct. 6 of them had hormonal treatment. But Maki, I didn't look into each different study to see what interventions they've had, whether they were fertility patients or anything like that.
Okay, quite interesting. I wonder from the audience, or from you guys actually, how many of you discuss routinely diets and supplements in clinic? Because I know I do, but I also refer patients, or I try to refer them at least to dietitians if they can. Avril, you work with me, so I know your answer. Kyle?
I'll highlight it as a complementary alternative therapy, but I wouldn't necessarily give specifics. I think this study's nice. Did the authors, Avril, do they give if you are to give something, we recommend giving this, anything like that?
No, they didn't say that. It was
No.
just a vague that anti-inflammatory supplements
Mm.
can improve pelvic pain. Didn't say
I
this is
think
better than that, this is more superior than that.
I think nutrition, we need to think about nutrition differently to pharmacology. And I probably would bring anti-inflammatory diet and supplementation more under that than I would say pharmacology. And I think sometimes as doctors, we want to think of these things like meds, don't we? And we want to have very clear X, Y, Z, but there's so much more that goes into it. And that's why I think it's good having our allied colleagues, because they have such a better and wider depth of knowledge with these specifics. I don't know what you think, Mikey.
I think you're spot on there, Kyle. I think you've literally highlighted exactly what we needed to say. Miriam has her hand up. Avril, you the host. So do you want to let Miriam actually tell us?
Let me see how I do that. I need to stop the sharing first.
Okay.
Okay, hand up, allowed to talk. Yep, I've done it. So Miriam, you can ask your question.
Hi, can you hear me?
Yes.
Yeah.
Hi, Miriam.
Okay, good evening to everyone, and thank you for the lecture. I'm a medical student here in Italy, and I also have a stage 4 endometriosis. I wanted to tell you about my personal experience with anti-inflammatory. Actually, I decided to go to an anti-inflammatory protocol since mid-November. This is my personal experience, of course, but before that, I was diagnosed like 3 years ago, and before I go on anti-inflammatory protocol, for like, I don't know, 5 6 months or maybe more, I was in constant pain, pelvic pain, and also in my thighs, and it was like a hellish situation. It wasn't like at some point it wasn't bearable for me. And in mid-November, I started anti-inflammatory protocol. I didn't take like vitamins or other supplements. I just went on anti-inflammatory protocol, so just the food and stuff. And honestly, the improvement that I have seen is like unbelievable for me, because I had a lot of literally inflammation in my face, in my body, in my belly and stomach. I even had like my intra-abdominal pressure was so high that I started to have like acid reflux. It was putting pressure on my stomach. And then after I could see the like effect of it after 2 weeks. Like after 2 weeks, um, everything started improving. I right now, of course, when I'm on period or around ovulation, I still have like pain, but there is no constant pain anymore, and also I feel so much more comfortable in my body. Um, my belly, like my pelvis. I don't have like pain in my thighs anymore. So I just wanted to like share this experience with you because for me it was unbelievable, the effect of this diet, and I think it really works.
Thank you so much, Miriam. I think it's it's really actually brave for you as a medical student to come and speak up. So thank you for that. And I think you're absolutely right. Yes, well, so well done. And I think you're absolutely right that I'm a strong believer in diet. I'm a strong believer in physiotherapy and acupuncture. I think it's important to highlight that it doesn't potentially work for everyone. And I've seen now, there's patients that will respond really, really well to anti-inflammatory diet. There's some patients that might not necessarily have that positive response like you did. However, I think it's always important for us to keep that in the back of our heads that yes, it's a valid option for a lot of patients. So thank you so much for actually coming and sharing your experience.
Of course, I just wanted to share my personal experience. I understand that it might not all patients would have the same reaction.
Brilliant. Thank you, Miriam. And thank you for joining.
Thank you. No, thank you.
Right. What are we presenting next?
Yep.
Mm-hmm.
So essentially, this study was published in the Journal of Minimally Invasive Gynecology. Now, postoperative pain management has got such far-reaching implications on the overall recovery, hospital stay, healthcare costs, etc. But there has not been a conclusive sort of recommendation on whether TAP blocks are better or wound infiltration with local anesthetics are better than, which one is better over the other, and a superiority of a technique has not been established. Hence, the study tried to look at a meta-analysis of randomized controlled trials, looking at this comparison between TAP blocks, which are transversus abdominis plain blocks, and wound infiltration with local anesthetic. Before we go ahead, for those who do not know, TAP blocks were introduced sometime in 2001, and this involves administration of a local anesthetic into the neurovascular plane between the internal oblique and the transversus abdominis muscle of the abdominal wall. And what they do is they target the lower thoracic nerves, which is T7 to T12, and iliohypogastric and ilioinguinal nerves, which arise from L1. Next slide, please. So the meta-analysis essentially included only randomized controlled trials, and they looked at basically, as I said, the intervention that was compared to local anesthetic infiltration into the wound was post-operative TAP blocks, and adult patients who underwent gynecological surgical procedures were included. So laparoscopic procedures and laparotomy both were included in this analysis. And the primary outcome that was studied was the post-operative pain at 1 hour, 4 hours, 12 and 24 hours post-surgery. And the secondary outcomes that were analyzed were the overall post-operative opioid consumption, the opioid-related side effects like post-operative nausea, vomiting, and overall patient satisfaction. Next slide, please. So a total of 10 randomized controlled trials were included. 7 were double-blinded, 3 of them were single-blinded. A total of 604 patients were included, wherein you had 304 patients in the TAP block group and 300 in the group that received wound infiltration with local anesthetic. The local anesthetic that was primarily used was bupivacaine in both the groups. Some studies looked at including levobupivacaine, and one of the studies had used liposomal bupivacaine. 5 of these studies focused on post-operative pain management following a laparoscopic surgery, whereas the others were included laparotomy as well. And most of these procedures that were included were comparative in terms of the overall operative time, in terms of procedural complications, if any. And 4 or 5 of them included only benign procedures, whereas the others included malignant and benign. And some of them were awaiting on histology, so they did not really distinguish them into only benign or only malignant. Next slide, please. So as you can see, this is the forest plot showing post-operative pain, which was the primary outcome analyzed in this paper. And if you see the forest plot for 1 hour, 4 hours, 6 hours, 12, 24, and the overall, you can clearly see that it crosses the line on the TAP side. So the TAP block is providing significantly lower pain scores compared to wound infiltration with local anesthetic. And the greatest pain reduction was actually observed in the first 12 hours. However, sustained benefits were seen at 24 hours as well. In terms of one of the other outcomes that was also looked at in terms of secondary outcomes was the need for rescue analgesia or any add-on analgesia. And it was noted that the patients who received TAP blocks had lower need for any rescue analgesia or additional analgesia in the first 24 hours again. Next slide, please. The other results, as you can see on there, the overall opioid consumption was also significantly less in the patients who received TAP block as compared to just local infiltration with an anesthetic into the wound. Opioid-related side effects, which primarily were looked at, which primarily included nausea, vomiting, were similar in between the 2 groups, and no significant difference was noted. In terms of patient satisfaction, there were only 2 studies which assessed this, and one of them showed a significantly higher satisfaction in the TAP block group, and the second one was inconclusive. And the 4th one, which I've already described, the time to rescue analgesia. Again, limited data on this, but whatever data there was suggested that the TAP block delayed the need for any additional pain relief or rescue analgesia as compared to wound infiltration with local anesthetic alone. Next slide, please. So the conclusions of the study being basically that TAP block outperforms wound infiltration with local anesthesia in post-operative pain control and also reduces the opioid consumption in the post-operative recovery period. However, we require further large-scale randomized control trials with longer follow-up periods because the maximum follow-up we had in this meta-analysis was up to 24 hours. So longer follow-ups are needed for confirmation of what this meta-analysis is to suggest. The strengths of this study were that only randomized control trials were included, so the bias was significantly reduced. There was detailed pain assessment at multiple time points, and there's clinical relevance in terms of what we can apply in day-to-day practice, which supports TAP block as superior pain control strategy. The weakness, however, being there was high heterogeneity in terms of the different surgical procedures were included at one go. And we all know that there are different anesthetic protocols and pain protocols in place as well. And quite a lot of times, these are also suited to the personal preference of the surgeons and the anesthetists involved in the surgery. So this led to a high heterogeneity in the analysis. And as I already highlighted, that there is limited long-term data because the follow-up was only up to 24 hours. And some of the studies were also affected by small sample sizes. Thank you.
Brilliant. Thank you. Thank you very much, Megan. Do we have any polls actually for tablets? Did we create any polls, guys? Avril, Kyle?
We haven't created a
We
poll.
haven't.
No.
Okay. Well, another interesting, very interesting, quite interesting presentation, which is really good. I must admit that I don't routinely do tab blocks myself, although I'm quite dependent on the anesthetists that I work with, and sometimes some anesthetists actually do ask us to put a tab block, but routinely I don't, at least. Right. Do we have any? What else do we have? What other presentations?
Next presentation is by me again. Okay, so this is looking at the prevalence of small intestinal bacterial overgrowth and intestinal methanogen overgrowth in endometriosis patients. So basically, SIBO is the excessive growth of bacteria in the small intestine, and this bacterial overgrowth can disrupt the bacterial balance in the gut, and this can lead to symptoms like abdominal pain, weight loss, bloating, diarrhea. So what this study wanted to do was to see the prevalence of SIBO in patients with endometriosis, to see if we can make any global recommendations for the care of endo. So what they did was, so there is a lab in Marseille which patients will come to get a breath test to get investigated for SIBO. So between November 2021 to June 2023, 1,027 women went to the laboratory. They then gave these women a questionnaire, self-reported questionnaire, to see whether or not they had endometriosis. And those women who were suspected to have endometriosis based on the questionnaire, they then went to look at the patient's medical records, and endometriosis was confirmed by either MRI or surgery. So in the end, from that 1,027 women, they diagnosed 149 patients. These 149 patients were then age matched with the remaining 878 patients who didn't have endo or who are thought not to have endo based on the questionnaire in a 1-to-1 ratio. So they then had 148 with endo and 148 without endometriosis. Out of those who had endometriosis, 1/3 of them had stage 1, 21% had stage 2, 9% had stage 3, and more than a third, just over more than a third, had stage 4 endometriosis. So these are the results, and what they found was a greater prevalence of SIBO in patients with endometriosis compared to those without endometriosis. So 91.9% of patients who had these GI symptoms and endometriosis tested positive for SIBO. They then looked at the symptoms, and the things that they found were statistically significant was that women with endo had a higher prevalence of altered transit time compared to those without endometriosis, which can then lead to bowel symptoms like constipation and diarrhea, but these were not significant. So diarrhea is over here, and it's the p-score is 0.071. Constipation is over here, and the p-score is 0.069. They then also looked at extra digestive symptoms, and what they found, symptoms that were higher, statistically significant and higher prevalence in patients with endometriosis is headache, fatigue, and dizziness. Also
Sorry,
acknowledge,
before you
sorry,
go on,
yeah.
if you go to the previous slide, the patients that were diagnosed with endometriosis, so that was the 148 out of them. They were cross-matched with 148 patients that didn't have endometriosis, and this is based on just a questionnaire, or did they have further imaging?
You mean for those without endo or with?
Exactly.
Without? No, just a questionnaire. So so they gave a questionnaire, and if this questionnaire didn't indicate that they have endo, then they are in the without endometriosis group.
Okay.
Yeah.
Okay.
Yep. So they also acknowledge that these women being a real life cohort, they can have one or more pathologies. So then they created distinct subgroups where they only looked at patients with endometrial without any coexisting pathology, and they found without any coexisting pathology like IBS or any form of conditions, and they found a higher prevalence. So if with coexisting condition, the 91% tested positive for SIBO. Without it is 94%, so much higher. And these are the results of the patients without the coexisting pathology. And the only thing that they found was statistically significant was the altered transit type. Oops. So the conclusion of the study is that this is the first case control study to report that 91.9% of women with endo who self-report digestive symptoms have a positive SIBO test. The prevalence of extra digestive symptoms like headaches, fatigue, and dizziness was significantly higher in women with endometriosis who tested positive for SIBO compared to those without endometriosis. So what they have advised is abnormal digestive overgrowth should be assessed in all patients, in all endometriosis cases, as this approach could offer a new therapeutic strategy. I did some reading about what type of strategies we can give these patients, and that consist of prebiotics and probiotics and postbiotics.
Okay.
And that's all from me.
Thanks, Avril. That's quite interesting. Interesting study. Carl, do you have anything to add?
No, I mean, with all these studies, that I think the intention and the finding out's very good. It's so hard to refine them, like that diagnostic criteria or of not endometriosis. You could even say, well, look, we know that probably 10% of these people do have it, and then is that a factor? So those bits are difficult. Yeah, non-invasive testing will make things easier.
Yeah, exactly. Right, and I think we've got still time for the last paper. Maga, are you presenting the last one? Yeah?
Yes, I am. Okay, so given the emerging popularity of robotic-assisted laparoscopic surgery in the recent few years, this paper looked to evaluate the safety and efficacy of robot-assisted laparoscopic surgery versus conventional laparoscopic surgery in the treatment of endometriosis. Next slide, please. So again, this was a meta-analysis which included 14 studies in the analysis. A total of 2,700 patients were included within different stages of endometriosis, ASRM stages from stage 1 to 4. Overall, the study focused on comparing one of these 6 outcomes between robot-assisted laparoscopic surgery and conventional laparoscopic surgery in the treatment of endometriosis. And the 6 parameters included whether they were intraoperative complications were comparative, post-operative complications, the overall operative time, the conversion rate to a laparotomy, estimated blood loss, and the total hospital stay. Next slide, please. So these are the number of studies who looked at those particular parameters. So if you go to see that there's absence of significant differences between robot-assisted surgery and standard laparoscopic approach for endometriosis surgery in terms of intraoperative complications, post-operative complications, the conversion rate, and estimated blood loss. However, the patients in the robot-assisted group have longer operative time, and as you can see, the P was significant, less than 0.001, and hospital stay, which was also longer than those in the laparoscopic group. Now, among the factors that could be contributing to the extension of the time required to perform the robotic surgery is docking of the platform and overall expertise and experience with robots. However, these are also directly proportional to the team's experience, and they're expected to decrease as the learning curve progresses. Regarding the hospital stay, the paper postulated that this could also be attributable to a bias in the fact that the robots surgeries are usually preferred for people in worst health conditions, for example, like morbidly obese, etc., were selected as candidates for robotic surgery rather than conventional laparoscopic surgery. Next slide, please. So these are again forest plots looking at the analysis that I've just described in terms of intraoperative complications, postoperative complications, and the conversion rate. You can see that the overall diamond crosses the line of no effect, a line of zero effect, meaning there is no difference between the robot-assisted group and conventional laparoscopy in those outcomes. However, next slide, please, as the next two graphs would show us that there is a significant difference between the robot-assisted and the conventional laparoscopy in terms of operative time and hospital stay between the two groups. Next slide, please. So the conclusion being that despite the growing global adoption of robotic surgery and the increased expertise amongst surgeons, there's currently insufficient evidence to establish the superiority of robotic surgery over standard laparoscopy when it comes to endometriosis surgery. The strengths of this paper included that the recent papers were included in the analysis, and the methodological accuracy and assessment of bias was quite thorough. The limitation, however, being that most of the studies that were included in this were retrospective, with only one trial being prospective. And also that all these papers had the Da Vinci platform as the only robotic system analyzed. The limited reimbursement for robotic procedures and the extended overall operating time remains significant concerns, particularly when you juxtapose that with the absence of any discernible differences in perioperative outcomes. Thank you.
Thank you, Megha. That's always been a question, sort of, even when patients are asking whether the operation is going to be done robotically or laparoscopically. My approach is always that it is really the same operation. It's just a different tool that we using it. I think there's certain benefits of the robot, specifically for parametrial disease. When we're operating in tight spaces, we're talking about sort of sacral nerve roots or lumbosacral trunk. So those patients, I think, will benefit greatly from a robot, reimplantations, thoracic endometriosis. But equally, essentially, I think that at least that's my approach, that pretty much all operations can be done laparoscopically. That's my take on it. I'm sure every surgeon is going to have their own opinion on it. For someone like you guys that are still in residency and training, what is your view on robotics and laparoscopy? Where do you think, where does that stand in comparison, not in comparison, but where do you see this as part of your overall training? Kyle, Megha, Avram?
So I think the robot is a tool that we need to be accustomed with, whether we like it or not. I happen to like it, and therefore I think it should be certainly access to it even as an assistant should be there from early on, because actually there's a lot of fiddling and learning that's needed to get used to being assisting robotically as well. I agree with you that it is a tool. I think it can offer a platform that facilitates multidisciplinary surgery in a easier way. So let's say you've got 3 organ disease infiltrating the vagina, the rectum, and the urinary tract. The fact that everyone can operate on the same platform from the same ports and still be very happy about it is a nice thing. But equally, that still can happen with laparoscopy.
Yes, certainly. I think again, you're spot on. Those operations that require multiple surgeons, robotics is, I think, definitely has this positive. That's very true. Right, I think we're getting closer to the time of closure. It's almost 7 o'clock. Do we have any questions from the audience? Let's just have a look. I don't think so. I don't see anything. Right, on behalf of the team, I want to thank you guys for presenting today. Well done, Kyle, Maga, and Avril. Thank you everyone for joining us tonight. And when is the next one? It's on the 6th of next month. Do we have a flyer to put up yet or no? Not yet?
No, we don't have a flyer yet.
Not a flyer yet. Okay, so hopefully see you all next month on the 6th at 6 p.m. UK time. Have a good evening, everyone, and thank you for presenting,
Thank you.
guys.